referred to in this presentation as the unspoken casualties. If you are not aware, I myself am a veteran. I served in the United States Army, 2nd 113, 42nd Infantry Division as a 19 Delta Cav Scout during the thralls of some of the heaviest of my alcoholism, and it had a major effect on my career as well as everything in between. And this has become a subject that is very near and dear to my heart as I now work in the recovery field. And I am proud to be able to represent veterans and first responders today. And I hope that we all have a moment to learn something about the struggle that these brave men and women and others are going through. So with that, I'll get into the presentation. So the bond in honor and suffering. There is no question in anyone's mind that our persons in uniform are the sword and shield of our society. Cultures all over the world turn to the brave and the willing who serve their nations to protect their very way of life. But what of their needs? What happens when their heroes are suffering? What happens when the very people we thank for their service succumb to the physical and mental wounds of their duties? We ask so much of the individuals who volunteer to put their lives on the line for us, yet despite the efforts of many, our response to their struggle is still greatly lacking. The scars that veterans and first responders carry with them for their tours of duty have led countless numbers towards substance use disorder, criminal behavior, and suicide. Many service people go undiagnosed for a myriad of reasons, whether it's a lack of health care, the fear of being ostracized by their peers, or the stigmas placed upon them by society. Many in uniform will fall prey to addiction, trauma, and suicide. This is not because they are weak. This is not because they have a socialistic disorder or lack of a will to survive. This is because the pain is left unchecked. This is because they believe the nightmares will never end. This is because they believe we have abandoned them. Today, we have the opportunity to change this terrible cycle for the better. During this presentation, we'll explore the history of substance use disorder among the military, the impact of PTSD and SUD on the veterans and first responder population, the services that are available, and the obstacles standing in the way of our heroes to receive them. By the end of this discussion, let us find a way to lessen the distance between what is being done to what can be done for our veterans and first responders within the recovery community. A mirror image. The connection between veteran and first responders comes from the understanding of duty to something greater than oneself. The core values of the services that uphold safety, stability, infrastructure, health, and welfare of society transcend all boundaries. It is no wonder that many who begin their careers in one uniform often find their way into another after their tours are complete. For instance, a survey conducted by the Marshall Project in 2020 indicated that while only 7% of the U.S. population has served in the military, by that year, 19% of the police officers around the country were veterans of the military. Firefighters and emergency medicine also made up the list of top 10 professions chosen by veterans after retirement from military service. There is an underlying vestige of respect within the professions that make transition between them natural. With this, however, comes the shared burden of withstanding the difficulties these commitments demand, sometimes far beyond what any average human being should have to endure. It is not without some understanding that many would turn to nearly anything to help alleviate the pain often accompanied by these hardships. This trend of self-medication did not begin at random. The culture of addiction was introduced to the military community, perhaps even earlier than many of you would think. So now we discuss the cost of service and start with the Civil War. It may not be known to many, but addiction in our military are almost as old as our nation itself. Brittany Tackett, an author of the American Addiction Center, has published an article containing some of the history of recorded use of narcotics within historical military events. The first recorded use of drug addiction in the United States was during the American Civil War. Morphine was the drug of this war. One of the Union officers supposedly made his command members drink opium daily as a preventative for dysentery. Soldiers left the war addicted to morphine and continued to use it at home where it was readily available. An estimated 400,000 soldiers returned home addicted to morphine. For this reason, morphine addiction was known then as the soldier's disease. World War I. According to Lucas Kamenetsky, a political science professor at the Institute of American Studies in Polish Diaspora, and author of Shooting Up, a short history of drugs in war, cocaine also became a drug of abuse on the front lines of World War I. People turned to the drug to boost energy, combat fatigue, and reduce wartime anxiety. It gained popularity when the British Army created a drug known as forced march, a combination of cocaine and a kola nut extract. People then began to self-prescribe the drug as a wartime aid. Amphetamines were the most popular drugs used in World War II. In fact, soldiers accounted for the largest number of amphetamine users between 1939 and 1945. The United States, Japan, Britain, and Germany administered amphetamines to their troops. For example, the British Army consumed an estimated 72 million benzodrine amphetamine tablets during the war. The American Army used even more amphetamines than the British. The Pentagon issued between 250 to 500 million benzodrine tablets to U.S. troops during the war. Benzodrine was added to American emergency bomber kits in 1942, and in 1943, they extended the practice to the infantry. Approximately 15% of American soldiers took the drug on a regular basis. Often referred to as the Forgotten War, the Korean conflict was not without its uses of now illicit narcotics to supposedly enhance our Marines and soldiers' capabilities. Newly synthesized amphetamines were widely distributed to the military personnel as pep pills. According to We Are the Mighty Veteran Publishing, American servicemen stationed in Korea and Japan began concocting the speedball, an injectable mixture of amphetamine and heroin. Many became dependent while in the service and continued using after the war. Speed was a popular drug for American soldiers in the Vietnam War as well. The American military issued 225 million tablets of dextroamphetamine between 1966 and 1969. Dextroamphetamine was twice as strong as benzodrine tablets given during World War II. These so-called pep pills were given out like candy with no attention paid to dosing or frequency. Speed was far from the only drug used during the war, however. During use in Vietnam, drug use in Vietnam was quite common. At least half of the soldiers used marijuana and a third of them used heroin or opium. The Department of Defense provided sedatives and neuroleptics to soldiers to help combat the intense stress and mental breakdowns associated with war. For the first time in history, antipsychotics such as chlorpheniramine were given to soldiers. And even though these drugs drastically reduced the number of mental breakdowns in the short term, they were given without psychotherapy. The use of dextroamphetamine also caused long-term problems for soldiers. Speed increases aggression as well as alertness. When the drug wore off, the soldiers were often irritable, leading to incidents of insubordination with fellow soldiers and superiors alike. Unfortunately, the soldiers were not able to detox from the drugs before being sent back home. Instead, they reportedly suffered serious withdrawals on the flight home. Those that arrived home were often offered little to no support, and many battled addiction and PTSD. This trend of introduced narcotics for both heightened performance, mood stabilizers, and stress relief will continue through every major conflict to this day. It's recorded that alcohol use is more prevalent among military men and women than among civilians. Almost half of active duty members report binge drinking in a 2008 survey, an increase of 35% in a decade. Research indicates that binge drinking rates are even higher among those exposed to high combat. Illicit drug use is less common in military personnel than in the public, but prescription drug use is on the rise. Data from the Department of Defense reveals a significant increase in prescription narcotics for active duty troops during the Iraq War, from 33,000 a month in October 2003 to 50,000 a month in 2007 of September. Research indicates that prescription opioids such as Percocet, Oxycontin, and Vicodin are commonly abused. Energy drinks, no-dose, and dextrogen pills are also widely used to help maintain energy and alertness. When it's time to come down, prescription drugs such as Ambien and Restoril are taken to help soldiers fall asleep and relieve anxiety. First responders are by no means alienated from the struggles of job-induced stress, leading to addiction disorders. The American Nurses Association has indicated that up to 10% of working RNs may be dependent on drugs or alcohol. However, the most worrisome statistics suggest that between 14 and 20% of all RNs in the U.S. may have a problem with drug or alcohol dependence or abuse. This speaks to the suspected prevalence of unreported cases. By this estimate, 1 out of every 5 to 7 RNs may be affected by an addiction disorder. According to a 2010 study by the National Institute of Alcohol Abuse and Alcoholism, 16% of female police officers and 11% of male officers show at-risk alcohol use. According to the First Service Joint Labor Management Wellness Fitness Initiative, alcohol is the most commonly abused substance among firefighters. Surveys by the Center of Fire Rescue and EMS Health Research revealed that 85% of career firefighters reported past month drinking. Most reported at least 10 days a month, or about half of their off-duty days. So behind the casualties lies the why. Not to diminish the obvious reasons why our service people fall prey to addiction, one of the most prominent causes of substance use and suicide for our veterans and first responders is the struggle with post-traumatic stress disorder, or PTSD. This disorder is not exclusive to people of service, but for the sake of our topic today, we will discuss the direct effects PTSD has on the veteran and first responder community regarding mental health and addiction. As we discover in the following slides, the types of PTSD and the origins of their development in an individual will largely be dependent on the individuals themselves. Let it be said that there is no one greater form of suffering over another. All who experience trauma experience their own personal form of hell. Rather than judge the severity of the cause, let us remain focused on understanding and treating this disorder as a life-threatening mental health crisis it is. It has been the lack of respect and disregard of this disorder in the past that has caused so many to befall the ultimate symptoms of its burden. With furthering education in events such as this, and keeping the topic fresh on the minds of those in a position to make progressive differences in the treatment options, we stand a better chance to minimize the damage caused by PTSD. Although now a household common acronym, few people can properly describe this disorder. This is of no personal fault, only that the details are rarely discussed beyond the damage it causes. To fully understand why this is one of the leading causes of addiction and ultimately death among our service persons, let's take a few moments to understand what it is and the dark relationship it shares with these professions. For those who have experienced a traumatic event, it is typical for the symptoms of stressful experience to linger well after the event has passed. The U.S. Department of Veteran Affairs defines acute stress disorder as a mental health problem that can occur in the first month after a traumatic event. These symptoms of extreme stress affect daily life. Post-traumatic stress disorder is a mental health condition where the symptoms of extreme stress have affected the person's daily life for a period over a month after the original event took place. So the major differentiator of ASD and PTSD is the time of suffering for the individual. People with PTSD have intense, disturbing thoughts and feelings related to their experience that last long after the traumatic event has ended. They may relive the event through flashbacks or nightmares. They may feel sadness, fear, or anger, and they may feel detached or estranged from other people. People with PTSD may avoid situations or people that remind them of the traumatic event, and they may have strong negative reactions to something as ordinary as a loud noise or accidental touch. PTSD can be accompanied by a wide array of co-occurring disorders. Seizures, schizophrenia, anxiety disorders, and bipolar disorder are among the many those who suffer from PTSD will live with in conjunction to their struggle with trauma. Left untreated and undiagnosed, PTSD can be an obvious cause to substance abuse. Many turn to self-medication rather than bring their problems up to their chain of command or of their families. This is largely due to the fear of judgment, repercussions, or stigma they may face when revealing that they are dealing with a mental health disorder. Another common outcome, not as commonly spoken of in public circles, is the heightened rate of suicide among veterans and first responders. Many of these cases can be linked directly to PTSD and substance use disorders. Another common outcome, not as commonly spoken of, when speaking of suicide among our service personnel, the facts are alarming and outright horrifying. Although some of the statistical numbers have indeed lessened over the past few years, they remain alarmingly high. According to the 2021 Annual Veteran Suicide Prevention Report published by the Veterans Association Office of Mental Health and Suicide Prevention, there were 6,261 veteran suicides reported in 2019, which by comparison represented 13.7% of the suicides among U.S. adults in that year. That's approximately 17 veterans a day that took their own lives. USA Today reported that 103 firefighters and 140 police officers were reported to have died by suicide in 2017, compared to the 93 firefighter and 129 officer line of duty deaths, according to the Rudderman Family Foundation. In 2019, a first of its kind study was conducted in Fairfax County, Virginia, among 911 and emergency dispatchers. It was reported that they found 911 dispatchers experienced suicidal thoughts at a rate more than double the general population. This was contributed to the trauma received from fielding emergency calls from the public. The pandemic has added enormous strain to the healthcare workers, particularly nurses, who provide most of the bedside care. A study was conducted under the supervision of Matthew Davis, an associate professor in the Department of Systems, Population, and Leadership at the University of Michigan. In the study, Davis and his team poured over suicide risk information for adults 30 and older, drawn from the National Violent Death Reporting System. More than 159,000 suicides occurred during the study timeframe, 2007 to 2018. Of those, nearly 2,400 involved nurses, roughly 8 in 10 of whom were women. The study authors noted this information correlates with estimates indicating that 80% to 85% of nurses are women, placing the female healthcare worker population at high risk to work-related suicide. So what is being done? With such tragedy and hardship facing veterans and first responders suffering with addiction and mental health disorders, it is easy to be jaded and not see the efforts being made to minimize these statistics. For example, launched in 2007, the Veterans Crisis Line started with 14 trained responders working out of a call center in Canaganooga, New York. It's grown to include an online chat and text service with 500 responders in 3 call center locations nationwide. Because many of these responders are veterans, they're familiar with the challenges veterans face. Continuing care after the call, chat, or text, Veteran Crisis Line responders can refer veterans to a local suicide prevention coordinator. Available in each VA medical center across the country, SPCs can connect veterans to the counseling and services they need. Responders are also available 24/7 to help active duty service members and their families find and friends through a crisis, through the military crisis line. Service members, including members of the National Guard and Reserves, along with their loved ones, can call and receive free confidential support. Since 2009, the VA has worked to reduce the prescription of opioids to veterans by using what is called the step care model, combining pain management with CBT-based counseling to manage chronic pain without heavy dependence on pills. Together with the VA's Opiate Safety Initiative, VA has successfully maintained a downward trend, reducing opioid prescription overall by 63%. The VA has also worked to increase the number of in- and outpatient facilities across the United States by creating more clinics and emergency health care locations throughout the country. The U.S. military and first responder units all over the country offer enrollment in courses referred to as SART, Substance Abuse Recovery Programs, for their active, retired, and veteran personnel. These programs are designed to assess and treat substance abuse disorders through outpatient and intensive outpatient programs. More and more clinical teams are also turning to evidence-based therapeutic approaches, when dealing with the SUD or maladaptive behavior. Civilian providers are making more of an effort to reach out to the veteran and first responder community. Windsor Laurelwood, a treatment center for mental health and substance abuse disorders, began the Guardian program, which specifically catered the chair treatment to fit the needs of military and first responder clients. Dr. Eric Peterson and his colleagues from the RAND Corporation recognize that young veterans are often unlikely to seek care at traditional VA medical centers. Researchers have begun to develop alternative novel methods of treatment, engagement, and delivery. For example, Dr. Peterson developed a web-based single-session intervention to reduce alcohol use among young veterans. In just 2 weeks, using Facebook as a recruitment site, they recruited a sample of 784 veterans. The intervention uses personalized normal and feedback and was found to reduce number of drinks per week, as well as binge drinking 1 month later. The advantages of an intervention like this one include the fact that it's required no clinician time or patient travel to a VAMC. In addition, web-based interventions reduce other barriers to care, such as stigma. Established evidence-based recovery programs, such as Smart Recovery, have begun to modify their programs to specifically fit the veterans and first responder demographics needs regarding SUD and PTSD treatment. Set to launch within the UK in 2023, then to follow shortly in the US, Smart Recovery is developing the Smart Veterans Program, which, similar to the Family and Friends program of the same nonprofit, will focus specifically on the catering of the CBT-based tools and life skills of their program for the particular needs of the veteran and first responder community suffering from SUD, MHD, or behavioral emotional maladaptive disorders. Problems with our connectivity. With so many organizations bringing these resources online for their personnel, why are numbers still so alarmingly high for this demographic regarding substance use disorder and mismanagement of mental health? Because there are still so many obstacles standing in the way of recovery progress. For instance, rural areas. According to the VA Office of Rural Health, there are 3.4 million rural veterans that comprise the total number of veterans enrolled in the VA healthcare system. Access to care, particularly mental health services, is problematic for veterans residing in rural areas due to lack of technology available, transportation issues, and facilities being few and far between. Female veterans. In recent years, rates of problematic substance use among female veterans have been increasing. SUD diagnosis among female veterans utilizing VA services has increased by 81% from 2005 to 2010. Some female veterans may feel uncomfortable seeking SUD treatment within the VA. Female veterans may find it difficult to disclose substance use to providers due to perceived stigma and shame associated with being a female substance user. Additionally, female veterans with SUDs have higher rates of childhood sexual abuse, military sexual trauma, and domestic violence than female veterans without SUDs, and women with PTSD are particularly at risk at developing substance-related problems. Stigma. Another challenge to treatment that is sometimes encouraged by veterans is the stigma associated with seeking SUD treatment. Efforts to integrate SUD care within the context of other mental health care would be helpful. So instead of having to seek care at an addiction clinic, veterans could be seen at a general mental health clinic that would address a myriad of issues, i.e. anxiety, depression, bereavement, PTSD, couples and family therapy. Furthermore, integrating SUD care into primary care would take it another step further in reducing stigma and increasing access to care. Additionally, the hypermasculine military and first responder culture often places importance and value on self-reliance. Therefore, military veterans and their responder brethren may be the more likely to strive to solve mental health issues on their own and view getting professional mental health treatment as a sign of weakness. Additionally, they may feel the need to help protect family or friends by not talking about their stigma or struggles. To hear their voices. These challenges are no secret, and every organization that services the veteran and the first responder community is aware of the hardships this population goes through to receive the help they need. But how many of us have taken the time to listen to a veteran or responder speak about their experiences? How many of us have been privileged to be trusted with seeing the people who we so readily call heroes at their most vulnerable? For the sake of this presentation, we had the honor of interviewing volunteers from the Smart Recovery Veteran and First Responder National Group meetings, which they dubbed themselves the Smart Team. The following slides are portions of their real-life struggles they have faced in their journey to achieve recovery. For the sake of anonymity, the names are not listed, but their testimonies could not be more authentic. No one ever grows up saying they want to be an alcoholic. As an EMT, I was involved in responding to numerous fatal accidents. Some continued to haunt me long after the incident. I was having thoughts and dreams about them, analyzing in my mind over and over what I could have done differently that could have made for better outcomes. It was driving me insane. PTSD wasn't really talked about much back then, with just the exception of military war vets. I didn't know it was even considered a thing in my fire and EMS community. Steve, 30 years retired fire and EMS. The trauma is repetitive. In some shifts, you don't have time to process one before another is being thrown at you. Seeking recovery treatment is scary for active nurses and health professionals because of the fear of being reported to the board. I've had to hide my recovery from my employers and others because I fear for my license, even when there are no legal issues involved. Amy, 24 years, emergency trauma medicine. My first experience with recovery was when my wife went to a magistrate and had the cops take me to the hospital. That was a bad move. My PTSD, coupled with my intoxicated state, led to a situation where the cops almost shot me. Sending armed men into a home of someone with PTSD from combat may not always be the best move. People with PTSD, in my experience, can have exaggerated fear reactions and aggression. The Army did a poor job of identifying my problems while I was in, even though I had been to mental health treatment before I got out of the service. I was diagnosed with general anxiety disorder and sent on my way. I eventually entered IOP, which was difficult for me, listening to people complain about their petty issues when I was upset about babies being killed and the like. If my trauma had been identified earlier, it would have been much easier for me. Pete, 8 years retired Army infantry. As I am still active duty, I cannot speak to the retired veteran experience, but here in the Navy, it's clear that AA is forced on us as a end-all, be-all recovery group. I think this is really demotivating. It presents distorted thoughts along the lines of, if I don't fit into this program, then there is no hope for my recovery. One size does not fit all. I had to request the use of Smart Recovery as my recovery group, as it was unknown to the Navy SARP offered to me. Jane, 12 years active duty Navy. These men and women suffer for more for their commitment to their professions, countries, and communities, more than most of us will ever know. It is deplorable that they should suffer more when simply wanting to find help for themselves. There are many out there, indeed many in this very conference, who are giving their all to make a difference in the veteran and first responder community suffering with addiction and mental health disorders. But we can still do so much more. Henry Ford once wrote, "Coming together is a beginning, keeping together is a process, working together is success." One of the major changes required in recovery community to invoke change is open communication. The one size fits all, or our way or the highway mentality, is an antiquated approach to modern treatment. One of the first aspects that needs to be accomplished is to first stop looking at the problem from a point of excuses. It doesn't matter what any of us believe addiction is. If we lose ourselves on the constant debates over what this disorder is or isn't, we lose the opportunity to save more lives. While serving in the military, I was accustomed to being presented a problem and multiple ways of approach to overcome it. We didn't waste time or energy contemplating why the problem existed or who was to blame. We knew people were counting on us to do our jobs, and we put our focus on exactly that. This is absolutely no reason we cannot start doing the same within the recovery community. What that means is creating an interconnecting link of resources across multiple platforms of recovery services. This is a change that will start from the very top of the government providers to a nonprofit community drop-in center around the corner. As organizations begin to offer multiple pathways of recovery for a wider array of problematic disorders, with more inclusive mentality for any and all to fit a successful means to their personal recovery goals, we begin to see less and less of our servicemen and women succumbing to these dreadful numbers of lost lives. Combining resources at one generic location will also limit the amount of stigma associated with seeking help. The stigmas and stereotypes that have plagued addiction for hundreds of years need to stop, period. They are not only holding us back from modernizing recovery, but literally costing us lives. How many men and women suffer needlessly because of their fear of revealing their disorders to their employers? How many have fallen prey to the darkest forms of addiction because the help never came? How many have lost their lives because they decided to cease to exist, rather than live with the pain, guilt, or shame? As organizations that employ these individuals, we count on to maintain the comfortabilities we take for granted in the society. There needs to be an abundance of understanding, of support, and resources for those who are desperately seeking answers. A service member should not lose their badge, rank, privileges, or position permanently because they are suffering from a medical disorder. They should be given the same honor, respect, and dignity we award them when we shake their hands, hug them, or simply state, "Thank you for your service." If you are in an organization that aids the veteran and first responder community, make sure you are offering all they require to reach their goals. If you do not have services for these brave men and women, find out how you can connect to others who do, to link what you can offer to better their lives. If you are not involved in recovery at all, but want to do something to make a difference, reach out to those in your communities, networks, and institutions that are, and find out how you can be of service. No problem is insurmountable. We have the opportunity to form a coalition of the willing, to face a common threat together, united. Let us find better ways to serve those who have proudly served us. And with that, I conclude this presentation, and I thank you all. References for the information that I shared today are found at the end of the slide, and I have provided those to Nicole and Jamie. So if anyone's interested in learning more about where I found this information, you can look on the slideshow for that. And with that, I will give it back to you, Nicole.